Hello. Test, test. All right. Hello, everyone. Welcome to CPC. My name's Emma. I'm one of the chief residents here, and I'm very excited and sad that this is my last CPC of the year, at least as a presenter. Yay! And today we have expert clinician, Dr. Mohamed Babiker, and it's his first CPC. So yay for coming and being a sport and telling us all your thoughts. As you guys know, this is much more about the journey and hearing you walk through the case and less so about the destination or the diagnosis. So we're very excited to learn from you today. So let's meet our expert, Dr. Mohamed Babiker. He is an assistant professor in the Division of Rheumatology. He went to medical school at the University of Khartoum in Sudan, and then residency, he came here to Chicago, where he did his residency at Amita Health St. Joseph Hospital, and then he joined us at WashU for his rheumatology fellowship. And now I'll go to our case. We have a 66-year-old female with a past medical history of CAD, status post PCI, HFpEF, hypertension, Afib, cirrhosis, type 2 diabetes, and hypothyroidism, presenting with progressive volume overload, fevers, and eye redness. Dr. Babiker, I'm going to hand it over to you. I'd love to hear your initial thoughts. How are you approaching this combination of issues?
My first, impression is that I couldn't pinpoint right away which direction I'd be, focused on, because there's kind of multiple symptoms going on or active issues. But obviously, having a fluid overload, fevers, and eye pain, I would think of multiple system kind of a disease versus infection. So obviously, I would want to dissect the cause of each of these active issues.
Yeah. So going into our HPI to learn a little bit more, about a month prior to admission, our patient reports that she had this onset of bilateral lower extremity edema, despite escalating her home BMX. She also reports 3 to 4 weeks ago, she had this right groin thigh lesions that were noted to be like an abscess by her PCP notes that she got a course of Bactrim for. They didn't really bother her, but she notes that they bleed pretty easily. Then 5 days prior to admission, she developed a sore throat, a productive cough with white sputum, shortness of breath, chest pain, orthopnea, now needing 2 pillows from her usual one, and intermittent subjective fevers, though no measured fever. She was evaluated at urgent care. She got a dose of prednisone and some antibiotic we don't know, and that didn't really help, unfortunately. So the day of admission, she wakes up and suddenly she has bilateral upper extremity swelling and bilateral conjunctival injection, worsening of these symptoms, and that prompted her to go to the ED. For some patient details, she has a history of HFpEF. She notes that she follows with a cardiologist, but unfortunately we can't see those notes in Care Everywhere, as well as CAD, status post to PCI to the RCA. A few years back, she's on hydralazine, Isordil, BMX, Plavix for these issues. For Afib, she's been offered like an ablation, but she's deferred. So she's on diltiazem and sotalol. She was previously on amiodarone about a few months back. She has this history of cirrhosis that may be MASL D, but she hasn't had any known complications from this. Type 2 diabetes, she's on insulin, glimepiride, and metformin, COPD, and OSA because of her extensive smoking history, 60 pack years, smokes a pack a day, hypertension, hypothyroidism, and she's on Synthroid for this. So in terms of our surgical history, she did have a cholecystectomy and hysterectomy. For family history, you're a rheumatologist, so I thought you might want to know. She does not have any history of rheumatologic disorders. And then for allergies, she has an ACE allergy with tongue swelling and an alpha-gal allergy, though she tolerates dairy. And then she lives in rural Missouri, does not have any pets. She's not super outdoorsy, so she's not spelunking or anything like that, not a gardener. No other drugs, and then functional status. She's independent with her ADLs, and then intermittently uses her walker and cane. I would love to stop here.
Yeah, let's go back to the first one.
Yeah, let's go to the first
The HPI. There's a lot going on.
Yeah.
So initially we were saying edema getting worse and a groin lesion with bleeding. So I'm assuming some ulceration going on. And then 5 days later, so this is my initial thing is that, if I'm thinking down the road of autoimmune diseases, I would worry about, infiltrative process versus vasculitis, or kind of a lupus type of picture. Even though the age, that's why I will put it down a little bit for the lupus. And then moving to the 5 days prior to admission, sore throat, productive cough. It sounds like lung involvement is happening along with chest pain, so cardiopulmonary involvement. And the fevers are along with the constitutional symptoms. So beside the autoimmune processes, I would honestly worry about infectious causes like infective endocarditis, or even atypical diseases. You did point out no pets, but that would have been one of my questions. If they have any cats, just think of like Bartonella type of picture. And the reason why I always emphasize on the infection is that it's tragic if we miss it and we assume this is an autoimmune process and we start treating with immunosuppression, which would obviously lead to poor outcomes. So that's why my emphasis always is more common causes, secondly, infection, and then autoimmune diseases. Now, moving on to the day of admission, worsening of the edema, and then eye involvement, and then progression of symptoms prompting ED evaluation. Now, when we add the eye involvement into the picture, it does narrow down a little bit my autoimmune causes or etiologies. So commonly we would worry about vasculitis, sarcoidosis, and less coming in the list will be rheumatoid arthritis and then lupus for these patients.
Great. Next slide.
Past medical history, a lot, but the typical. So we had the heart failure and coronary artery disease, which could explain, as part of my differential, that is a heart failure exacerbation, or sepsis leading to heart failure exacerbation. Cirrhosis, can't make much of it besides maybe low protein production that could also lead to the volume overload. So I do have a lot confounding, or at least a lot going on that could explain some of the symptoms happening. And then looking at the medications, as a rheumatologist, when I see hydralazine, I always worry about drug-induced lupus or drug-induced vasculitis. And this could actually be one of my differential for the patient. The rest, can't make much of it for now. So let's see what else.
Yeah. I'll give you our review systems and our physical exam. So many of the things we already talked about for the HPI, she's having subjective fevers, fatigue, eye redness. She's also reporting some mouth pain now. On palm exam, shortness of breath, dyspnea on exertion, these recent URI symptoms. She has a lower extremity edema and orthopnea. No active chest pain, but has reported it. And then GI, GU, heme, MSK, nothing really notable on review systems or neuro or psych. And so for our physical exam, she is febrile, hemodynamically stable on room air. Her BMI is 57.8. Notably on HE and T exam, she has bilateral conjunctivitis. She has this 1 centimeter beefy red lesion on her tongue, 2 ulcerative lesions on her inner lower lip. She doesn't have any notable JVD, no lymphadenopathy. She has diffuse wheezing on palm exam. Sorry, it's not in red, but otherwise cardiovascular exam, there's no extra sounds. For skin exam, she has a right inguinal region, small bleeding blister. And then on MSK exam, this pitting edema, 2+ noted in her hands and her lower extremities, and then maybe more like 1+ in her upper extremities. And I'm sure you wanted to see our pictures. I know you're not a dermatologist, but how do you think about these assorted skin, tongue, and eye findings?
It's obviously raised, erythematous, and looks like small vessel formation or angiogenesis type of or hemangioma type. Can't make much of it, to be honest, but looking at the conjunctivitis also helps me kind of narrow down a little bit of my, rheumatological causes. So with the sarcoidosis, I would worry more about uveitis, not conjunctivitis, scleritis. Maybe could go more with the rheumatoid arthritis. Maybe also um, lupus, but it kind of lowers my sarcoid a little bit. So yeah.
Wonderful. And then here are your initial labs. So this is our initial CMP. I've bolded in red the things that were on Epic, noted as not baseline or not normal. Anything pop out at you?
First thing I looked at was the kidney function, see if that explains the fluid overload, which was obviously normal. I'm looking at the calcium, see if it's hypercalcemia, which will point me in different direction towards the sarcoidosis. With a patient known to have liver cirrhosis, I'm not making much of the LFTs in this sample, but I see low albumin, which kind of make me worry about protein loss, which still could be renal picture causing the fluid overload.
Great. Here's the CBC. It's a normal diff. And then
normal diff, okay.
TSH is normal as well.
Okay, good news.
So before we jump into, I'd love to hear all the diagnostics you want, but how are you putting all the pieces together? Like, what's your problem representation here?
Biggest thing is I want to rule out infection in this patient and kind of gather or figure out what exactly is causing the fluid overload, or at least assess the vital organs that seems to be involved in this picture. So we did the first thing, which was getting the basic blood workup. I'll add to that our rheumatological panels that we usually get, looking for vasculitis. I don't always like to add ANA, but since I'm not quite sure, I will add it because it's in the picture of using hydralazine. I would worry about that. And then I will extend that panel by adding complement levels and so what do we call antihistones antibody for this patient. And then for the sake of organ involvement specific to evaluation, I would want to have the urine protein or spot urine protein creatinine ratio and urine analysis. I would also looking for hematuria in this patient. Even though the creatinine is normal, maybe it's early in the course of the disease. Obviously, I would want to have an echocardiogram in this patient, assessing the valves, assessing the function of the heart. Not necessarily jumping to liver ultrasound yet, since we haven't pointed towards like abdominal symptoms going on. But also would want an opinion of ophthalmologists about any concerning findings on an eye exam.
Wonderful. Let's do our cardiac eval.
Okay.
So we on EKG, normal sinus rhythm, tropes were within normal limits. ProBNP was elevated at 962. We did get the echo that you wanted, which unfortunately showed poor acoustic windows. There was a normal LV size. It was hyperdynamic. EF was 75%. We couldn't see the diastolic dysfunction. There was some RV dilation and normal valves. And then because there was lower extremity swelling, we did get a Doppler, which was negative.
So seems like heart failure picture with a raised BNP.
Mm-hmm.
Not a lot that I got from the echo except the valves are intact. But the EF and the not knowing the diastolic status is kind of iffy because that's one of the things I would want to know if they have like kind of constrictive disease going on. But yeah. Well, what else are we going to?
Yes. Well, we did get some imaging. Chest X-ray. Okay. Small left pleural effusion with left lower lobe atelectasis. And then we did get a CT cap with. There was moderate cardiomegaly, concentric pericardial thickening, and small pericardial effusion, suspicious for constrictive pericarditis. We also see a cirrhotic liver with sequelae of portal hypertension. They noted splenomegaly, gastroesophageal varices, and portal colopathy. And then there were some nodules in the lung with a recommendation for a repeat in a couple months. They did, I guess, noting the cholestatic liver pattern, they did get a right upper quadrant ultrasound, which wasn't that exciting. There was no ductal dilation. They noted the gallbladder was absent and cirrhotic findings. You had spoken it into existence.
Yeah. But am I allowed to ask questions
Of
in the
course.
history?
I mean,
I would honestly ask about the hydralazine initiation. When was it given first?
she's been on 100 milligrams twice a day for about a year.
Okay.
Why do you ask?
Because of my concern of drug-induced lupus in this picture. Because now I'm seeing, multi-organ involvement, the heart with the constrictive picture. And I'm suspicious also there might be some protein in the urine. The lesions, I think it can go with lupus, but I'm hoping for a dermatology input in these cases. And also waiting on the results for the antihistones antibody.
Yeah.
And the ANCA too.
We got some initial infectious studies. You also had wanted that.
Okay.
RBP was negative, blood cultures were negative, HIV negative, acute hepatitis panel negative.
Okay.
And the urine. Thank God Dr. Chang's in the audience to witness, but unfortunately, it's not very exciting. There was 1+ blood, but no RBCs, WBCs. There's no protein or anything in the
Good
urine.
news.
Huh?
Good news.
Good news.
Not for me though.
All right.
Oh no, what is that?
I
did
see
not
that you
agree on that.
recently published a chapter on critical care rheumatology in the Washington Manual. Congrats. Perhaps this will be clinically relevant quite soon.
I hope so.
So our patient, the day that she's admitted, she starts to notice this progressive lip and tongue edema with a muffled voice. So we get ENT involved, and they note that there's supraglottic vocal fold edema on the flexig. Here is like a picture from that evening and into the next morning. You can note that there's some swelling of her lower lip and worsening of these ulcers. Just stopping right here.
Yeah. Now when we see, purpura kind of picture or erythematous skin changes, I worry about vessel involvement, small, medium, with the tongue lesion as well, kind of headed towards also vasculitic picture. And the vasculitis could be either an ANCA-associated type, or it could be also drug-induced vasculitis. So when we look at these medicines that cause lupus, drug-induced lupus, they actually sometimes cause drug-induced vasculitis, and the picture is not that far from it at this point.
Are you worried at all about like angioedema? Are you starting any
Yeah.
medicines or stopping any medicines?
Did we go over the list of medicines? We did.
She's still on hydralazine and all her home meds.
No, obviously hydralazine, I would stop it. And, of course, we have a lot of alternatives that we can offer, at least in the interim. So it will be something I would like to hold off. Maybe steroids with the worsening angioedema picture. That's what I would do for now.
Yeah. This is also her eye the next day. So there's been progression of her ocular disease. So we get ophtho involved. Thankfully, there's only surface level findings, so conjunctival swelling, subconjunctival hemorrhage, and some perilimbal deposits with preserved vision, normal pressure, intact motility, and a healthy corneal surface with a normal retina. So no posterior chamber pathology. And then there's been progression of this rash. So derm does get involved and they do get us a biopsy, but you may not see it yet. She's treated with IV steroids and antihistamines, as you noted, and then she's actually escalated to the ICU for airway watch. Unfortunately, despite being okay on supplemental oxygen, she gets worsening dyspnea and she's nasally intubated emergently. And here, in the order that we got them, here are some initial rheumatologic labs.
So we have obviously elevated inflammation markers, ESR and CRP, which would go with, pro-inflammatory state for the patient. The ANA is obviously very elevated, positive, strongly positive. So again, that will direct me towards the picture of drug-induced lupus. And then additionally, the low complements C3 and C4, that also points towards active lupus picture, but it's not, very super reliable if we don't have a prior complement, because sometimes they are deficient, maybe because of the liver cirrhosis, for example, or because baseline they have hereditary deficiency of these ones. But still, overall, the picture is truly pointing more towards drug-induced lupus versus vasculitis.
So are these rheum studies like a slam dunk rheum issue? Like, how do you think about false positive rheum studies?
Well, the slam dunk will be actually getting ANCA and anti-histamine antibodies. The anti-histamine, if it's positive, it would point me definitely towards drug-induced lupus. And the ANCA, usually in the picture of drug-induced vasculitis, we have what's called discordance between the, both the C ANCA and P ANCA will be positive. At that point, it will be actually almost slam dunk. But I hate to use that term just relying on the labs, because there are sometimes we actually very rare kind of atypical chronic diseases that could mimic vasculitis and point us away. I'm always afraid of conditions like Bartonella, that it could give me positive ANCA, give me positive ANA, and all of these. So if I'm going to start this patient down the road on immunosuppression, heavy immunosuppression, ideally I would want a biopsy just to be comfortably commit to it. But for this patient specifically, I'll wait on these labs, and if they do point that, probably just gonna go for it, high dose steroids.
And you mentioned Bartonella. Any other infectious things you might be worried about?
I would say the Q fever, blasto, not as much though. These are, I can't recall at the moment exactly what other that would mimic this picture.
Yeah. And then given like the angioedema picture, are you calling any of your other friends potentially in the hospital?
I don't know, allergy?
Yeah. All right. So I can give you some of that information. We did get further infectious studies. The histoplasma, blastococci were all negative. We did get tick-borne illnesses. So Ehrlichia and Anaplasma were negative, Rocky Mountain spotted fever. CMV and EBV were like slightly positive, and T-spot was negative.
Well, it sounds helpful, reassuring. That doesn't seem to be viral picture, viral syndrome. So.
And then we did get our immunology friends involved. And I know you are not an immunologist, so I can have them call in as a consult. But they were worried about maybe like an inherited deficiency of like the C1 esterase inhibitor potentially with this angioedema. That was normal though. So they looked at a lot of different things, and they essentially concluded that probably need to be repeated outpatient, but you can see this low CD4, CD8, NK cells in like the setting of acute illness and recent steroids. They also mentioned that we should get SPEC because of that high IgM. There was an IgG kappa paraprotein, but kappa lambda free light chains were mildly elevated and the ratio was 1.5.
One of the things I'm a little bit, not able to make much of is the elevated IgE. Is that part of the, hypersensitivity kind of picture, or is it part of a vasculitic process like EGPA? Now with the heart involvement, and I remember you mentioned earlier the CBC differential was actually normal. There was no eosinophilia.
No eosinophilia.
But we also check IgE levels, and when we suspect, a type of vasculitis that involved the heart, like EGPA, and now seeing IgE, I might also put it back on the differential in this case.
All right. And then I think just because this patient got a lot sicker, and there was some like slight downtrend in the hemoglobin and platelets, we got some anemia studies. They were worried maybe about HLH potentially, but IL-2 was negative. LDH was like mildly elevated. Otherwise, things weren't super exciting here. So I will show you your rheum studies. What do you make of these?
It kind of goes exactly what I suspected, which is the positive antihistones antibody, while the rest of the panel that would be positive, the anti-Smith and anti-RMP with like a de novo lupus picture. But when I see only positive antihistones, I'm worried about drug-induced lupus in these patients. And then the ANCA being strongly positive and with discrepancy between the two, having both positive, that's actually very classical for drug-induced vasculitis. Now, for this patient, the picture seems to show involvement of the heart in a pattern that's more consistent with lupus picture. The tongue lesion kind of go more with vasculitic picture of the drug-induced. The lack of kidney involvement, doesn't help that much actually. But yeah, now I'm actually
Does
very
it like
concerned.
exclude the diagnosis if there's no kidney?
No, it doesn't exclude, but I look at it from treatment standpoint, how aggressive I'm gonna be, and what is the long-term regimen for these patients. If I have like a really bad kidney involvement, I would definitely get a biopsy done, and if it points toward lupus, I would treat as such. But usually they're common shared treatments for the both, but it's part of like prognostic approach rather than defining kind of picture.
Great. And we can finally get to our biopsy as well.
Hey.
So I would like to invite Maddie Techner. She is a former pathology chief, and she's now a fellow in dermatopathology here. Thank you so much for being here.
Hi, everyone. Happy Friday. So we received one biopsy from this patient from the left thigh. You can see at low power on just the H&E that there's a lot of inflammation kind of scattered all the way from the epidermis down to the deep dermis. So you can't really tell at this power what kind of cells these are, but usually this type of look gives you an idea that it's going to be acute inflammation. So we'll take a closer look at high power. And on high power, you can see that we do have a lot of neutrophils, and there's kind of some like degranulating neutrophils almost. There's some dust, they're kind of dying. And then we also have these very bizarre kind of oval-shaped cells. They have a little bit of a central clearing, and then maybe a little bit of a capsule. So for us, this screams infection. So we did a lot of bug stains to kind of rule that out. Here's the GMS. So on GMS, any fungal or yeast form should be like a very stark black. And as you can see, there's nothing here that's really black. This is all kind of non-specific, dirty staining. So it's actually negative for fungal and yeast forms. We did a lot of the other infectious workup too. We did a gram, we did a PAS, those were all negative. So we were kind of like, this is weird. This actually looks like Cryptococcus, but it's not staining for that. So we used an MPO stain, and I'm sure you guys probably know this. This is usually used in like heme workup. It stains granulocytes and several other types of cells. The thing that we specifically use it for in DermPath is to find neutrophils that don't classically look like neutrophils. So you can see a lot of this kind of like dark brown staining here, and a lot of this kind of just pale staining in the background. So all of those cells that we were seeing, even those big kind of bizarre cells as well, are all neutrophils. And all of this is characteristic for a specific entity called cryptococcoid sweet syndrome. So essentially what this is, sweet syndrome just in general is a neutrophilic dermatosis. It's an inflammatory skin condition. And then sometimes when we see those oval-shaped cells, we call that cryptococcoid sweets, but it's coccoid, not cryptococcus. So this just means that it looks like crypto, but it's not actually. So this is not an infectious cause. And that's how we signed the case out.
All right. So at first, the team was really concerned that this was potentially Cryptococcus and this patient was getting high-dose steroids. We did get a Cryptococcus and a dilutional, which was negative. Then all the fungal stains also came back negative, and HSV was negative. So with that, what are your thoughts? What do you think the diagnosis is?
Diagnosis is drug-induced Vasculitis, I would call it.
Yeah. Cryptococcoid
no.
Sweets. No, you're right.
Okay.
It's
What
cryptococcoid
is that?
Sweet syndrome,
Cryptoid.
which is a skin finding of probably hydralazine-induced ANCA-associated vasculitis. So in terms of hospital course, she did initially get better with the swelling and the rash on these high-dose steroids, but unfortunately, she got a lot sicker in the ICU, developed acute encephalopathy that they thought was toxic, metabolic, nothing like structural on exam, slowing on EEG. So they thought, could this be a new infection potentially? Because she had now persistent fevers, uptrending leukocytosis. They did a lot of workup. A lot of it was negative. They saw maybe some palm opacities concerning for, a HAP or something, and maybe some sinal infection. She was on broad spectrum antibiotics, meropenem, vanc, acyclovir, and antifungal was eventually started. And they were just kind of treating empirically for meningitis because they couldn't do an LP. She got worse in terms of her anemia, thrombocytopenia, her liver studies, and the steroids were just decreased because of this concern for maybe infection. Because of this persistent encephalopathy and kind of poor prognosis, and the next steps were like a trach and a peg, which she had previously stated she would have never wanted. The family transitioned her to comfort care and she passed. So a little bit of a sad ending to our case today. I did have some teaching points on cryptococcoid sweet syndrome. You've already explained kind of what sweet syndrome is: painful erythematous papules, nodules plus fever, and a dense dermal neutrophilic infiltrate. It's usually like 3 categories: classical, drug-induced, or malignancy-induced. Cryptococcoid sweet syndrome is an extremely rare subtype. We're talking like less than 15 case studies. That is like a subtype of the histiocytoid sweet syndrome. I have a nice table here kind of comparing the two. Histiocytoid and cryptococcoid sweet syndrome are immature myeloid cells on staining. And of course, cryptococcoid looks like cryptococcus and is that's usually the common misdiagnosis, which obviously is not great when you need steroids. There was this paper by Lim and Lee that coined the cryptococcoid neutrophilic dermatoses, which is a more umbrella term to include the cryptococcoid sweet syndrome, but also something called iododerma, which is when there's too much iodine in your system, which you can only really see by getting high serum or urine levels. There was a hypothesis that could this be contributing potentially, but really unclear from the history. Maybe this amiodarone exposure in the past could have contributed, but we will never know. In terms of hydralazine-induced ANCA-vasculitis, you probably could speak more to this, but it's the most common drug cause of ANCA-associated vasculitis. The mechanism is that hydralazine forms covalent hydroxone adducts on MPO, which causes a neoadjuvant, which then causes pathogenic anti-MPO autoantibodies. So this is a true drug-induced autoimmunity. The serologic signature is pretty much what we saw in our patient. And you pointed out this dual MPO PR3 positivity as being pretty specific for that, in fact. And there's only 2 published cases that actually combine cryptococcoid sweet syndrome with hydralazine-induced ANCA-vasculitis. So very, very rare, but has been in the literature. And management is you stop the hydralazine and you do, steroids and potentially immunosuppression if needed. So thank you so much. If you have any parting thoughts, I would love to hear them. You nailed it. Great job on your first case.
Pretty glad. Thank you. It's truly a great case, and it kind of points out the details we have to go when we see, unclear type of presentations. But as a rheumatologist, these are the things we actually look at. The drugs truly first thing that popped up was hydralazine. I don't know why I put it number 1. Was it intentional or not? But it would be something I would look at always, because we do see it. It's like you pointed out also, it is the most common out of the other drug-induced causes. But again, I always emphasize trying to get a tissue biopsy is very important, because when we commit this patient to immunosuppression, and sometimes even to medicines like rituximab that has a half-life of over 9 months, it's very important that you rule out those kind of atypical infections. So, you mentioned that the reflex thing that the primary team did, they checked for Cryptococcus. I actually like that they did that, not that they misread the diagnosis. I think that would be my intuitive kind of thing of reflex I would do as well. But thank you very much. Happy to come again, I guess.
Yeah, great.
All right.
Great job.